I'm a clinical psychologist, and my expertise actually is in developing the psychological understanding and treatment of clinical paranoia when individuals have very strong, unfounded beliefs others are deliberately trying to harm them, a form of excessive mistrust. And it was notable right from the start of the pandemic that there were instances of excessive mistrust. So there were already beliefs around 5G and the virus. The idea of microchip implants were sort of circulating at that time. Some of these ideas seem very extreme and the reports were anecdotal. But what I wanted to do at the start actually was to take the temperature of mistrust. You know, how many people were actually believing these conspiracy ideas, this excessive mistrust, and did it actually matter? That led to our first ocean study published in May of last year, where we did a survey of 2,500 adults, a representative sample in England, and assessed over 30 different types of conspiracy beliefs. I'll just give you a flavour of some of the findings from this first study. What certainly shows we found appreciable endorsement, rather disappointingly, quite high levels of endorsement of these beliefs. For example, the idea that the virus was a hoax, most people didn't agree with that, but about 20% did agree to some extent. And then even higher levels of the general public were believing ideas such as the spread of the virus is a deliberate attempt to reduce the size of the global population. And really, in some ways, the content didn't matter so much, because if you endorsed one conspiracy belief, you're much more likely to endorse another. So, for example, you are believing that the Jews have created the virus, you were also more likely to believe that Muslims are spreading the virus. If you believed lockdown was a plot by environmentalists, you're also more likely to see it as a plot by globalists. So this speaks to this idea of a sort of conspiracy mentality that cuts across all these sorts of beliefs. We found only half of the adult population was untouched by conspiracy beliefs. Maybe another quarter had a degree of endorsement. 15% had a consistent rate of endorsement of these beliefs, and 10% had rather sort of strong levels of endorsement of these sorts of ideas. They also connected to existing conspiracy ideas, for example, about vaccination. So we also assessed beliefs about vaccine safety data being fabricated as well as effectiveness data, and again, ideas about conspiracy beliefs about vaccines and autism. What's interesting here is, again, another 20% are sort of endorsing the ideas, but another quarter of the population are kind of sitting on the fence. They're neutral about these sort of extreme beliefs. And in this first ocean studies, we found that these ideas probably do matter because they're associated with being less likely to stay at home, to not meet people with outside households, less likely to stay apart when outside, less likely to wash hands, less likely to use a tracing app, less likely to wear a face mask, also saying less likely to take a diagnostic test. And back then also saying that if a vaccine became available, they would be less likely to take it. So these ideas potentially do matter because they potentially drive behavior. Now, as I said in the introduction, I'm in the psychiatry department, a long way away from the vaccine developers, but of course, around that time we published the study, already there was amazing work developing the vaccine, and it was beginning to be trialled. And on one of my sort of morning lockdown walks along Port Meadow, it of course occurred to me that here we could see ahead that there's potentially a sort of defining test of trust, that when the vaccines were available, would people trust them enough to take them? And of course, it occurred to me that actually what we want to be doing is thinking about the messaging so that we could increase trust and dispel mistrust. And clearly, in that communications endeavour, it would seem hugely important to have a role by the people who develop vaccines. So I fired off a very speculative email to Andy and Helen, basically apologising for disturbing them, but is there any chance they might be interested in taking part in a multidisciplinary research programme trying to improve communication and reduce vaccine hesitancy? And I was delighted that both of them replied and agreed to take part in the rest of the work that I'm going to describe. The position we started on, most importantly, is before we could think about what messages most may be effective, is that we must understand the concerns. And that was our second ocean study, this time a survey of 5,000 adults across the UK. We assessed a huge number of variables, about 400 different questions were asked in that. We did two main structural equation models. The most important thing driving hesitancy was beliefs about the pandemic and vaccines, and there were four main types that explained 86% of the variance in vaccine hesitancy. And I'll just describe some of this. We also did qualitative interviews with some of the people from the surveys that sort of provide some flesh around these sorts of beliefs. But crucially, beliefs about the collective benefit of vaccination were important. So if you were more likely to be willing to be vaccinated, you say such things such as, so I think it's really selfish almost to think, oh, I don't want to get it just because you think it'll be fine. It's about thinking about others and coming together sort of as like a community. But if you were more vaccine hesitant, you would say these sorts of things. If then I get it, then that's my choice. It's like if I smoke, that's my choice if I want to shorten my life, because I know smoking will shorten my life. So it's just a personal choice thing. Also important was perceptions of the seriousness of the pandemic. So if you are likely to accept a vaccine, you say things such as, obviously surrounding areas have been bad and the country as a whole has been a mess, a total mess, and it is serious because so many people are dying. But the seriousness was viewed as much less. If you were hesitant, people would say, I still feel a lot of the figures are wrong because they seem to be putting things down to COVID, where they're not all COVID. We know that, everybody knows that. We're identifying concern around speed of development. So people who are willing to be vaccinated would say things such as, to get a vaccine ready in such short time, frankly, is quite amazing, and it shows how good our pharmaceutical industry is. And I think it's something to be proud of. The hesitant would say things such as, it's too short a time. I don't think there's anywhere near enough data that they've got. And personally, I think they may even know definitely they're using the general public as guinea pigs. Guinea pigs is a phrase definitely floating around. And then there were issues around side effects. So people who are positive would say things such as, any drug is going to have potential problems, which affect some people, but no, I don't think. But our drug companies are too responsible to allow a drug on the market, which was dangerous. The vaccine hesitant would say things such as, worried whether it could cause me do me any damage inside, whether these vaccines can damage your insides at all, liver, anything like that. So these beliefs were particularly driving views about vaccination, but they were also in the context of mistrust. And our second model showed a contribution of mistrust, explaining about 32% of variance, feeding into these beliefs and vaccine hesitancy. Mistrust was of many forms, really. So there would be conspiracy beliefs idea, but also negative views of doctors or vaccine developers, negative NHS experiences, and also some political beliefs, need for chaos, a sense of wanting to tear down institutions. And those who are vaccine hesitant were also less likely to report of respect towards doctors or having positive NHS experiences or positive GP experiences. They would also consider themselves of lower social status, both within their local communities and within the UK in general. We wanted to use these sort of understanding to think about, is there very specific, brief content we can give about the importance of vaccination above the basic statement of safety and effectiveness that may actually help to reduce hesitancy in the general population. This was a study with 15,000 adults in the UK. They were randomized to receive one of 10 different messages about vaccination. And then afterwards, they were tested on their willingness to be vaccinated for COVID-19. I won't go through all the results. I'll just give you a flavor that I think contains a sort of general lesson about this area, really. Our control condition was this, just the NHS statement that the coronavirus vaccine is safe and effective and gives you the best protection against coronavirus. It's been proved by the MHRA. Now, we'd shown the importance of beliefs about collective benefits underlying a lot of people's willingness to accept a vaccine. So we thought pushing this message about collective benefits may help reduce hesitancy. So messages such as the vaccine makes it much less likely to pass on COVID-19 to other people. So by taking it, we're helping to protect each other, family, friends, neighbours and colleagues. But that wasn't the message that reduced hesitancy in those who were hesitant. The one that changed hesitancy the most was actually personal benefit messaging. Messages such as this: we can't be sure, even if we're relatively young and fit, that we won't be seriously ill or struggle with long-term COVID-related problems. Taking the vaccine means we can get on with our life without worrying about what the virus might have in store for us. And of course, if you think about it in the perspective of those who are vaccine hesitant, they're not currently unwell. They don't actually think, they're less likely to think that actually they're at risk from COVID, but they do think they're at potential risk from the vaccine. And also they're more likely to be marginalized and therefore feel excluded from the collective. So collective benefit arguments for this group actually are less likely to carry weight. So when you're dealing with personal risk, actually the most effective messages may be about personal benefit. None of this is simple. There are added complications. We looked at moderation of these and shows there's potential differences for this message by age, by gender, and for some of the other messages by ethnicity too. So we're in a high stakes communication challenge, and this is going to confront us for many years to come. So we have to continue work understanding hesitancy and also developing evidence-based ways of reducing it.